So as you know, your doctoral project is designed to shrink this gap between what we know from science and research and evidence and what we actually do and practice in the real world. You're working to close that gap through your project. And one of the critical resources you need in order to close that gap is a roadmap, something to help guide you along the way. We talked about how your vision and theoretical framework can be that roadmap to help orient your project from start to finish. We're going to build on that discussion of an overarching framework as our guide and now dive into our methods section and talk specifically about variables. How are we going to quantify and measure what we're doing? So this is focused on quantitative variables. Certainly, there might be a variety of data that you're collecting with your projects. And since the majority of us this term are doing quantitative work, that's the content that I'm focusing on in this lecture. But if you need some input on qualitative work, certainly please reach out in email or mobile office hours, and I can work with you one-on-one to find more resources for your particular situation. But our vision for our DMP project is driving us to ask questions about practice. And when we start to ask those questions, we also have to have a strategy for rolling out and implementing our projects. And we talked about a hypothetical example of adolescent HIV medicine adherence at the Coptic Center for Infectious Diseases. So in a major urban center in East Africa, at this clinic, about 75% are female. The median age is 15. The racial background would say is Kenyan, but there are many racial ethnic groups represented in the capital city of Nairobi. But we don't have any data on those tribal ethnic linguistic backgrounds in our hypothetical example. Our patients are primarily near poverty with a high food insecurity and living in informal urban settlements. And the educational attainment we don't have any data on. 50% of our population have partners, and it was about 2 years since their last since they were first diagnosed with HIV. Now, if you think about using the findings from research for your practice setting, one of the critical things is not simply what the research article found, but the demographic composition of your research article. Because in this example of research on HIV, it was conducted in the Southeast United States in an urban setting. Half were female, and the average age was 42. The socioeconomic status at this time was measured by having a phone and a VCR. 94% of people had high school or greater education, and 82% were single, and it had been 11 years since their HIV diagnosis. So you see, when you begin to compare the target and the research populations, there are some marked differences. The US versus Kenya, you have 75% versus 47% female. You have age, one group is higher, one group is lower. And you have also a big discrepancy in the number of people in an intimate partner relationship and the number of years since HIV diagnosis. So if we wanted to pull the findings from that research into our practice, we might have to significantly adapt it. And when we're thinking about measuring what we're doing, this particular research article worked to improve adherence, and they measured adherence by the number of missed medications, including the last missed dose and the number of missed medications in 4 days. In our target population, we're thinking about measuring adherence hypothetically using pill counts for our DMP project and working with social work facilitated peer groups with 2 to 4 people per group and over multiple sessions. So we're also going to measure ART adherence by the number of medicines, HIV medicines in the bottle of a 90-day supply divided by the total pill count of 90. So we're going to use 90-day pill counts for adherence versus what they used in the research with the UCSF adherence questionnaire for this hypothetical project. So you can see there are differences in the research setting and the evidence we're bringing into our own practice. So there's an intimate relationship between our problem statement, how we design our project, what variables we collect, and what we do with our conclusions. So our hypothetical problem statement is related to adolescent patient adherence for HIV medicine being 50% lower than that of adults. The aim of our hypothetical doctoral project is to improve adolescent adherence by 25% up to 6 months after intervention. We're going to use social work facilitated monthly motivational interviewing sessions with peer groups that last for 30 minutes. So that's our intervention. We've looked at literature and appraised motivational interviewing as a good fit for our context. We've then have an objective around clinic-wide ART adherence before and after. And we're also going to look at individual adherence before and after 3 motivational interviewing sessions. So we have a clinic level measurement and an individual level measurement. And we've decided to measure adherence by the number of pills of a 90-day supply that remain on a clinic visit. The predictor variable for seeing if there's a change in those number of pills is having exposure to the motivational interviewing intervention package or not. We're going to collect those data with pill counts, and we're then going to analyze the number of pills missed with a Wilcoxon matched pairs ranked sign test at the individual level and a Wilcoxon ranked sum test at the clinical level. That will then help us conclude, does our package of motivational interviewing adherence counseling actually improve adolescent adherence to HIV medication? And those conclusions then are directly feedback to the problem statement. So each step of your manuscript design, from problem statement, aim, objectives, the specific variables, how you capture them, how you analyze them, and what sense you make of those findings, are all intimately related. And this entire design process can cohere around a theoretical framework or model to help you identify some of these key things, like the variables to be measured, and then how you structure your conclusions to take back to practice and science. So I've hopefully made the case that there's a strong relationship among these components, but then we think about measurement. What are we going to measure in our doctoral projects? So on this graph, there's the time is on the x-axis. So we have increasing time moving to the right, increasing difficulty, complexity, and cost on the y-axis. So if we think about collecting data for our project, there are 4 general categories of variables. There are process measures, output, outcome, and impact measures. So if you want to measure impact measures, it's much more costly, difficult, and complex, and it takes a lot longer compared to process measures. So there's no absolute right or wrong thing to measure, but it's critical to think about how much time and effort it's going to take to measure what you're interested in so that you can design your project strategically. So in our HIV example, process measure could be something like the number of social workers that are trained in motivational interviewing. It's a process that we've done. An output measure could be something like now that we've trained those social workers, they have output how many motivational interviewing sessions. So it still doesn't tell us about HIV control, HIV adherence, but it says from our project what's an output from it. Or it could be the number of patients in each of the sessions. Again, it doesn't tell us disease control, but it tells us something that has been an output of what we've done. Then when you think about an outcome measure, outcome measures might be the percent of missed HIV doses. Of those 90 pills, what percent of the doses are missed? It could be the percentage of patients who don't refill their medications within 90 days. And certainly, those measures are going to take more time because it's going to take time to develop the intervention, train the social workers, have patients come to see the trickle effect of how that impacts whether or not they miss doses or whether or not they refill their medicines. An impact measure might be something like the HIV incidence in serodiscordant couples. So what percentage of patients where one partner has HIV and one doesn't, what's the incidence of HIV transmission? That's much farther down the road from our intervention. Or it could be the percentage of patients with opportunistic infections within 1 year. Or even further down the road, HIV-associated mortality. How many people are dying from HIV that isn't controlled? So those take a lot more time, years and years to measure, especially for mortality. And of course, the cost is going to be much greater. So as you think about your doctoral project, many projects focus on output and outcome measures, the ones that don't take years and years to measure, but give you more of a hard clinical or population outcome compared to simply process, like we trained this number of people. So as you think about filling the gap between what we know from science and what we do in practice, you're going to look at the current state of practice where you are and what future state you might like to be at based on the scientific evidence, based on your own clinical expertise and your passions. And so the work of defining the gap between where you are now and where you hope to be is part of crafting your problem statement. And it's really a critical component that drives your project as a whole. So it's a little bit about the variables that you may want to collect, the kinds, and be having an informed decision-making process. As you write your methods section, part of the methods section is talking about all of the components we've surveyed, looking at the practice setting, describing where you're conducting your work, how you're designing it. We saw that the article from Mexico is cross-sectional at routine HIV appointments. And then they used, in this last example, the UCSF adherence questionnaire or pill count. So that's the instrument. Those key things are often in one very brief paragraph at the beginning of your methods section. Then you'll talk about your practice setting, the population, context, the sampling, how you're including patients or excluding them, how you're including units or hospitals or facilities or whatever is part of your work. You have to explain how you're including that in what you're looking at. Then you summarize the design. What are you doing? Are you doing cross-sectional data collection, descriptive work? Are you using an intervention and measuring the difference after the intervention? All of that goes in your methods section, including your analysis plan. What are your instruments for collecting data? What are the variables that come from your theory? How are you going to describe your patient or clinical population? And what are you going to analyze? If you use the UCSF questionnaire, what statistic will you use to compare the differences? And at the very end is usually 1 or 2 sentences explaining the ethical review process that was conducted for the work. You can see this information is captured in the design section of the evaluation table. And the synthesis table helps you pull all of the things together.